Okay, we're in the final stretch of a fantastic three-day conversation, conference, and I think building community. I'm Peter Goodhand. I'm one of the co-chairs of the International Health Cohort Consortium, and I'm also the CEO of the Global Alliance for Genomics and Health that you've heard mentioned a few times. It's my great pleasure to moderate the final session and then take us through into the close of the entire meeting. This session will follow the format that by now you're all very familiar with, 3 great talks, and then Pigeonhole-enabled Q&A, which we'll moderate. Focus will be on dynamics of population health within a shifting global health landscape, examining how population-level data can inform and enhance clinical practice. So living that theme of cohorts to clinics. First speaker from Precision Health Singapore, who will talk on the intersection of precision medicine and population health. Please welcome to the stage Professor E Shyong.
Well, thank you very much. I'm amazed that so many of you stayed around. So it turns out that the intersection of population health and precision medicine occurs in my office, and in those 3 or 4 people who are sort of desperately trying to sort of hold this together. So what I thought I'd share with you today is a little bit about the story that we tell. It's not what we actually do, but the story that we tell as to why the kind of work that's being done and has been presented at this conference is so important. And so it begins here, and that is, and you can replace Singapore with almost any country and recognize that the different people who live in different parts of the world have different experiences of health and disease, and these are just a few examples that we picked out, and this is what when we talk to our stakeholders in Singapore, but each of you will have one of your own stories. And in part, some of these things are going to be driven by genetic factors, and we've seen this slide over and over again, and Patrick also showed this slide on the right-hand side here, showing that we are seeing variants at different frequency at different populations, and this has to do with where we came from and who our parents were and who their parents were and how we sort of came to live in our parts of the world. And the genetics in itself is interesting, but is not the sole determinant. And I don't know whether Saumya is here, but this is Saumya's slide, and it basically shows variants that occur at different frequency in the gene that causes cystic fibrosis. And in essence, these are variants that have differing effects on the function of the protein. And with that comes a slightly different phenotype. And in the sense, and in particular, if you look at the variants that are more common in East Asian populations, what you'll realize is that it doesn't always manifest with the lung disease that we see that is more common in Europe. That in itself, I think, is important, but it's not the only thing. And I'm showing you now a piece of work that comes from Xueling and Cassie Spracklin, who put together this sort of large East Asian genome-wide association study for type 2 diabetes, and this is repeated across most diseases. You will see associations in one population that you don't see in others, and the vast majority of these are also a consequence of differing allele frequency and reflect our ancestral heritage. But if we think about the determinants of sort of health and disease, genetics is certainly part of it, but it's not the only part of it. And there are also these sort of behavioral patterns and social factors that contribute to the pathophysiology of disease. And then, in fact, once we start to come in contact with the healthcare system, the natural history becomes modified by the treatments that are available, and every healthcare system in the world is constrained. And in the end, what we are is a mishmash of all these things coming together. And what I like to think is that as we begin to put together these large population cohorts, is that opportunity to begin to unravel some of these things. And so this is how we think about the work that we do today. Sometimes it's just a ball of string and it's all tangled, and it's quite okay just to pick up one piece and begin to sort of gradually untangle it. And what you'll see is these factors that I've just talked about, the contributions of genetics, the environment, treatments that are available, and you can do this in one population. But the hope and the aspiration, I think, that we've all spoken about at this conference is that we bring this to the rest of the world and to families of all shapes and forms. And eventually, this isn't about Asian biology or biology from any other part of the world. It's a lens through which we will look at human biology. And I think it's really important that we sort of keep this in mind as we sort of go forward. So when we start to talk about the intersection between population studies and health, we need to sort of ask a question, is this really enough? And I can answer the question, I can tell you that it's not, but I also can't tell you what needs to be done in order to make this happen. And we've seen a variety of presentations across the various days, and some of these sort of incredibly complex sort of organizations, and it all seems sort of worked out. But each of us starts at a different point. And this is the journey that we took in PRECISE when it came to thinking about transitioning between population health or population science and healthcare. And what we did was we sat with our stakeholders and we broke down all the things that need to happen before we can even make data from a single variant meaningful to an individual person in the healthcare journey. And so there are all these multiple steps, and you have to actually solve the entire value chain before you actually see any benefit. And I often sort of think about, or sort of tell people that we're working with, and we need to remember that we study all these things in large populations, but population health is delivered one-on-one between two individuals, very often with a desk in between. And we really need to think about how we're going to make that happen. So this is the approach that we've taken in the Chief Medical Officer's office within PRECISE. And it turns out that I can't tell anybody what they need to do, and we don't know what we need to do. What I can say is why we do it, and that's up at the top here. And this is something that we've stolen from our Minister of Health, and I've added the word unnecessarily, because I truly believe that all health systems are constrained, and implementation science is nothing more than executing within those constraints. You need to understand what those constraints are, but when you can understand what they are and you can overcome them, then we have a situation where we can say nobody should be unnecessarily disadvantaged because they were dealt a bad genetic hand. So this is really a question of equity. How do we uplift those people who are unfortunate enough to be dealt a bad genetic hand so that they have the same opportunities to achieve the aspirations that they look for in life as everybody else? We can also tell people how we're going to go about doing this. And you know, so there's a sort of very clear definition of values, and it's important for me to point out that when I talk about equitability and accessibility, I'm not just talking about patients and members of the population, I'm talking about all members within the healthcare family too. This is a broad enough vision that anybody in contact with the healthcare system or who works within the healthcare system can see a role that they could play in delivering on this mission. Everything else in between is no more than a series of conversations between individuals in the system coordinating actions towards a common goal. This is how we did it. And I'm looking for Doreen because Doreen is the architect of this system. What we did was we reached out to the medical community and we said, okay, who's got ideas as to things that you want to do with a genetic test in the clinical, in the healthcare system? We felt that clinical leadership was important, but it also needs to be sustainable. And we said, if you have an interesting idea, we will take an application if you can find a partner who's a health economist and who's willing to model for us what you think the predicted benefit of introducing the genetic test into the clinical healthcare, into the clinical pathway would be. And we said that they could ask for money to do one of two things. If it's already been done somewhere else, but you're not sure whether it will work here, you can do stuff that is test a proof of efficacy. Or if it's already been done, but you think you can make it better, you can do work on implementation and try and make it better. We selected, in the end, 5 clinical implementation pilots. This was sort of through a review process that included all stakeholders, so gangs of 4 reviewers, 1 representing an economic agency, 1 representing the funders, 1 representing science, and 1 other got together and looked at these proposals and ranked them, and these are the 5 that got selected. And we were very pleased to see amongst them things that we would have thought were going to be important, but we didn't want to impose on the medical community. But we weren't prepared to stop there. What we said was, all of you can now come together and we will sit and we will look at these 16 steps that need to be delivered in order to change healthcare. And each of you needs to begin to start to think in your clinical pathway, what do you need to make this work? So we workshopped this, we gave out some additional funding to allow them to sort of build these sort of cross-cutting platforms. And in the end, where we are is that what Precise does is we facilitate and sponsor the conversations that allow us to sort of put together these cross-cutting platforms. And these are sort of broad ones that we've begun to identify as we've sort of gone through this journey. The overall goal, ultimately, is to transform the healthcare journeys. And as I said, very often this is delivered one-on-one, face-to-face in a doctor's clinic. So it's not enough to have great science. You need to make it possible for this to be delivered in this way. And the way to do that is really to sort of think about the whole journey and recreate the entire experience. There's no question that the digital transformation is going to be incredibly important. We still have sort of very inefficient processes, but just to give you an example of the kind of work that one of the pilots is doing, is that we're creating ways to bring genetic data into clinical records, have them drive best practice advisories that are designed by clinicians, that interrupt them only when it's necessary, and actually and deliver these at the point of care at a time when they're most important. So the question then I think we have to ask ourselves is, well, where do we start? And generally, the advice would be, well, what matters, to start with what matters most. It turns out that there are very few things that are right or wrong. And it turns out that in the vast majority of instances, what matters most depends on who you're asking. So if you ask the funders and the health systems, they're going to talk about the constraints or be concerned about the constraints that they face, and these are generally related to budget, cost effectiveness. If you talk to physicians, one of the things, and I just showed you sort of the work that we're doing in the space of sort of informatics and digital tools, is the cognitive burden that would be required and that would be added to what is already a very short, very, very packed sort of consultation on the part of physicians or any provider working within the system. And if you ask our patients, it's something else altogether. So I don't know where the right place to start is, but we think that maybe a good place is up here on the top left corner. Think about the things that matter to anybody. Look for the things that you can control, and maybe we can start there. Start pulling on any piece of string you can get your hands on that slowly helps you unravel this. And at some point, find a way to sort of knit these things together into the kinds of programs that you've seen over the last 3 or 4 days. And it really doesn't matter where you start. The important thing is to remember why you started, where you want to go, think about how great it will be, and keep pulling on this piece of string. This is what Chief Medical Officer's office looks like every day. You're laughing only because you know it's true. And I'll stop here and hand over to the next speaker.
Shyong, thank you for that, and a memorable image. We've seen many great images, but certainly the ball of string and the cats. And for being ahead of time. So we must be really focusing on the end of this meeting. Second speaker will address population genetics in an era of genomic medicine. I'd like to invite Professor Eimear Kenny from the Icahn School of Medicine at Mount Sinai in New York to come to the podium.
Hi. Well, thank you to Peter and thank you to the organizers for inviting me to this phenomenal conference. I'm going to, we've had a few talks today about really scaling up genomic health, integrating genomic information with other information in health systems. I'm going to spend today talking just about one health system. But it's an interesting place, at least I think it's an interesting place, New York City. And I'll warn you ahead of time, I have no videos of cats. I'm very sorry. So before I start, I just want to mention my own disclosures, and none of these roles is related to what I'm going to discuss today. And also before I start, just in case I don't get to the end, I want to acknowledge that I'm showing work from many talented faculty in the Institute for Genomic Health, Nora and Sabrina and Gillian, and also several members of my own group, postdoc Ruhi, newly graduated grad student Sinead, and 3 genetic counselor researchers in my group. Okay, so I thought I'd start by really stepping back a little bit and thinking about populations in the ultimate scale, which is our species, our own history, and how that has impacted the landscape of human genetic diversity that we see today, whether it's in the clinic or other settings. And this is an image that represents that, and it really starts with the emergence of anatomical modern humans in sub-Saharan Africa hundreds of thousands of years ago, and then the rapid migration of our ancestors around the planet to almost every place in the planet. And that has really impacted the variants that we see today. First of all, we're a very young species relative in evolutionary time. We've only been around for a very short amount of time, but we're a very traveling species, and our ancestors, and indeed ourselves today, travel rapidly and all over the world in many different patterns. And this has shaped how variants have emerged, sometimes in response to the environments we encountered when we reached different places, often not. And it also impacts the degree of diversity. So even though we're very genetically similar as humans, 99.9% identical at the DNA level, that 1% is very informed by the demographic history and the migration patterns of humans over time. And I've always been interested in this question, which really inspired me when I was looking for my own faculty job to go back to New York City about 13 years ago now, because New York is historically the melting pot of the US. It has been a point of migration to the US from all around the world for more than 400 years, and it's a highly diverse city. And you can think about diversity in multiple different ways and dimensions. Here's one of them. This is taking the view of the US Census, where they ask questions about race and ethnicity in the following groups. And you can see that here I'm showing you the 5 boroughs of New York City that are very colorful, representing different populations in the 70 or so neighborhoods across the 5 boroughs. But that's only one way of thinking about diversity. Diversity can be very dimensional. Another way, for example, is just asking people about their own heritage and memories of families and members and where they were born, and you see that there's a lot of rich heritage and culture also within the city. So this is what we encounter in the Mount Sinai health system in New York. Mount Sinai is one of several major large health systems that serves New Yorkers. We're quite large. My dean likes to say 1 in every 2 babies in New York City is born in a Mount Sinai health system. We see about 2.4 patient visits annually, so that gives you sort of a sense of how big we are. And on the top left here, you see the sort of footprint we have across the city. So you see we've got a lot of hospitals and ambulatory care clinics, principally in Manhattan, but also in areas of Queens and Brooklyn, less so, but still there a little bit in the Bronx and Staten Island, so that you can see the patients who walk into our health system, where they come from. And you can see that almost every neighborhood here is painted in purple. And in addition to the racial and ethnic diversity in New York City, we also have other types of diversity. So New York City is one of the largest degrees of socioeconomic diversity in the US, where people's salaries can range really wildly, and this, of course, has knock-on effects to their ability to access healthcare. And because of this diversity in our health system, we were one of the earlier health systems in the US to establish a biobank. And this was really in recognition that the diversity in our patients was not yet reflected in many of the genetic cohorts that were emerging and becoming available at the time. This was back in 2006. So that we better invest the resources to learn about the genetic profiles of patients in our health system and what diseases are important that we should be researching for them. And you can see, comparing what's now called the BioMe biobank to many other biobanks, it's certainly not one of the bigger biobanks that's out there, but on the axis of non-European ancestry representation, it is one of the most diverse in the US. Today, this is what our biobank looks like. There's about 70,000 participants recruited through the health system. It's fairly unselected, although it does tend to be recruited around certain procedure suites and things where we can get access to have time with patients. And in addition to generating sequence data for participants in the biobank, and this is done both through NIH funding and also through industry partners, for example, with Regeneron. We also collect questionnaire information about lifestyle, and we link to EHRs. And EHRs have evolved a lot in the time even since I've been at Mount Sinai, where our EHR ecosystem is quite complex, including not only the types of clinical notes and health records, but also increasingly digitized radiology, pathology, EKG, EEG, and other data types that are digitized and, even more importantly, starting to be made research ready and interoperable with other data types. So now we can really start to think about multimodal ways in which we ask questions. In addition to the other types of omics data, we don't have this writ large, but we have subsets within the biobank with deep omics data, and increasingly linking to social determinant health information outside our health system by geocoding to the types of databases that are out there that tell us about the lives of New Yorkers. So it won't surprise you to look at the genetics of participants in our biobanks and see a reflection of really our own human history, given that people walk into our health system who were born or their parents were born in over 160 countries around the world. So you can see this reflected here on this PCA, where BioMe participants are in gray dots, and reference panels from 7 different continents around the world are in colored dots, and you can see the overlap in terms of genetic similarity with the gray dots and the colored dots. And then the other thing that you can see that's very important is that there's no real discreteness in this data. This is unselected patient population in New York, and you can see we're seeing the continuum of genetic similarity across the continental groups here in New York City. But of course, the other thing that we know about our own history is that in recent time, we as a species have experienced enormous, massive growth on this planet. So to give you a sense, about 10,000 years ago, there was about 7 million of us on the planet, and Dr. Morris said it in the earlier session. Today, there's 8 billion, and some of that's happened, a lot of that actually has accelerated within our lifetime of us today. And this is also reflected in genetic data. So here is the representation of that demography, now just using genetic data. This is from work from the Exome Sequence Project back in 2012, where we sort of had enough data to first start to see this demographic history growth. And this has had a profound impact on what we see in the clinic today, because it means the vast majority of human variants entered our species extremely recently in time, and that those demographic events that happened very recently in time are going to be very important for understanding where we should see those variants. And one way that we can identify our recent human history is using shared haplotypes identical by descent. I won't go into this today because this is less of a nerdy science talk and more of a healthcare talk, but we can do it, is basically the upshot, and we do it using methods that we develop and we can run at scale. We've done this over BioMe, we've done this over all of us, where we've identified over 15 billion pairs of IBD sharing. And then you can use these to build networks, much like social media networks, where you learn from the topology of the network, the population structure in your data. And then when you do this and you start to overlay other types of information we may have collected, such as country of origin, and sometimes culture or religion, then you start to see much more nuance into the population structure that makes a lot of sense when we know about the demographics of New York City, and can be very important when we're thinking about what variants are important for which populations. And of course, we can also link this not only to tracing clinical outcomes. We've been digitized now for over 15 years, so we've got 15 years worth of data. But also these days, increasingly, when we have questions, we can get more nuanced, and we start using wearable devices or start to bring in more information that's relevant to particular questions from, like, for example, air quality and things like that. So here are some of the things that we can start to learn in a health system like this. And one is starting with a discovery step. And so we often start with an agnostic discovery step. In this case, we're doing something that's akin to a FEWAS, but we're just looking for diseases that are enriched in one group compared to everybody else. It's a very simple exercise. And when we do that, we see that an enrichment, a strong enrichment for medical codes related to peripheral artery disease that we see in Dominican populations that we don't see in any other population, and we don't even see in other Hispanic Latino populations in New York City. So then we go ahead and do a more epidemiological analysis of that and account for known clinical risk factors and social determinants that impact this. We see persistently that peripheral artery disease is at higher rate in Dominican populations compared to any other group that we look at in New York. And this is, in the literature in the US, something thought to be something that impacts mainly African-American communities. And we certainly see that there is an increased rate in African-American communities, but not as high as in Dominican communities. And now this can be for many reasons. It doesn't necessarily have to be genetic, but it does allow us to ask that question. And sure enough, when we go in and we start doing discovery analysis, we find that there is a strong locus on chromosome 2, right around the fibronectin gene, that actually travels with the Native American ancestry within Dominican populations that seems to be driving at least some of this increased risk that we're observing in that population. We can also look at the characteristics of populations, then discover, in fact, there's many populations within our biobank that are founder populations. Of course, when we see founder populations as geneticists, we know there's a chance that there's some medically relevant variants segregating at appreciable frequency in those populations that might be rare or absent elsewhere. And we find about 25% of our participants are from founder populations in BioMe, which is not just a feature of New York City. If you look at many other biobanks, and some of them have also looked at this, you see similar rates. So there's about 20% in the Atlas Biobank in New York, about 22% in the Geisinger Biobank. The FinGen Biobank has a lot of founder effects. Even in the UK Biobank, we found evidence of founder effects within the white UK-born Britons. So there's a lot of founding that happens, and when you spot it, then you can go with suspicion that there might be large effect monogenic variants in these populations, and sure enough, there are. So again, we can come with agnostic FEWAS-like approaches and discover, in this case, looking for recessive diseases, those that are segregating quite commonly within specific populations. In this case, we're looking at Puerto Rican populations where we catch two disorders. One was a known clinically described disorder called Steele syndrome, described in the 90s, around 2016, I think. A group from Baylor got the molecular alteration in collagen 27A1 gene. We were able to rediscover that in our biobank, but also show that it was a 1 in 50 carrier rate in Puerto Ricans. And because this was already known, we were able to immediately go to clinicians in our health system and to the medical genetic testing laboratory and set up a medical genetic test and start screening kids who are coming into pediatric orthopedics with hip dysplasia at birth, because this is a collagen disorder, for this disorder, and start to develop health management guidelines for treating children with this disease. We caught another one, which I'm less certain about, so this is now still sitting on the research side, which seems to be a splice variant in ABCB4, underlying severe liver disease in those with two copies. We don't quite yet know what that disease is, so we're needing to go back and do prospective work to figure out and clinically characterize what that is. And then the other point I want to make about diversity in biobanks and health systems is that nuance matters. It is both this continuous ancestry back through history and the discreteness of population groups that matters when we think about disease. It's just specific questions will have different answers. For example, for the APOL1 risk variants we found in our health system, that these kidney disease risk variants not only impact African Americans within our health system, but many other populations across our health systems who may or may not self-identify as with African descent, but also may harbor similar risk variants, are very understudied for how those play out in their life. And of course, it's understandable thinking about the specifics of slave trade in the mid-14th, 15th, to 16th century, and where populations were moved from Africa to various parts of the Americas. And now, of course, this doesn't just matter for the research side as we think about kind of coming into the translational space, also as we think about coming into new paradigms for genomic medicine. Our understanding of how different variants impact different populations becomes very, very important. And we have been, since 2019, really starting to build systems for genomic first medicine. As I mentioned, we were one of the first health systems with a biobank, not the first, but one of the first. So we've had a little bit of time, actually, to figure this out for our own health system and think about how to build programs like this. So I'll start with some things that we did early days. One of the first projects that we did was to really look at BRCA1 and BRCA2 pathogenic variant carriers within our health system and really try and get a picture of what's going on there. And it turns out that about 3/4 of the people who harbor a pathogenic variant in our biobank are unaware of it according to our health system's records. And of the 25% that are aware, it's only after associated cancer diagnosis that they have testing, so that's when they become aware. Even though we know that there are many cancers with lifetime associated risk for these variants, and that the prevalence of these variants can actually vary quite a lot between different populations. So for example, it's about 6-fold lower in Hispanic populations from the Caribbean compared to Hispanic populations from Central and South America. but also about behavior in our health system. So even though the risk, the lifetime risk for developing an associated HBOC cancer is about 25% for all our participants, if you're Ashkenazi Jewish in our health system, you're twice as likely to have been tested than not, which may speak to, it's just an observation, but it may speak to something about either the providers or the patients themselves and their own knowledge about genetic risk segregating in that population. So we did, back in 2018 and 2019, we did a big pilot study about how to implement a genomic screening program within BioMe, and we published a paper, and the upshot of that is we started with CDC Tier 1 conditions. This was after a lot of consultation with physicians and some nervousness about bringing this type of genomic information into settings like primary care. So with their agreement, we started with these conditions, but with some research and looking at other prevalent conditions, and specifically hereditary amyloidosis driven by a common variant in the TTR gene that's common at 4% in African American populations in New York and at 1% in Hispanic Latino populations in New York, we decided that it would be very important to add that too. And so we started to add that also to our screening program. And today, 1 in 35 patients in the BioMe Biobank have a positive finding through this program that we return. And of course, we also talk to our communities about their desire and attitudes to hear this information. And we published this study a couple of years ago in which we asked participants from our diverse communities. And in general, the desire was extremely high to receive this information in the context of clinical care given to them by their providers. And actually, if you look across different groups, the group that had the highest enthusiasm were predominantly Spanish-speaking women within our cohort, even though we were explaining that not all the evidence is there for some different population groups. And this inspired us to open a genomic health clinic back in 2020, where we could see patients who had increased risk and triage them, and sometimes that meant referral to high-risk specialty clinics. Sometimes it was finding early signs and symptoms of disease that we could intervene. This is also a clinic that sees people in our health system who, for their own reasons, may be curious about their genomic risk for disease. So we see them, but may not meet clinical indications to be referred for testing. So we see those patients too. And in doing this work, in collaborating with our clinicians who are seeing these patients, we've also readied our workforce, particularly the vast majority of medical professionals who are not genetics experts, by providing training. We have a genomic medicine residence track, which very soon will be available as an asynchronous virtual training that anybody will be able to access from around the world, and hosting very specific CME events to really coach and teach clinicians how to use this information. And we also think about delivery in terms of tooling. So we've been developing digital tools, and this is work on a tool called Guia.com, which can be used to return genetic results to patients. It's available both in English and in Spanish. And through the CSER Network NYC KidSeq study, we ran a clinical trial to compare this to traditional genetic testing and showed that using a tool that provided personalized visual aids and language ability increased parents' understanding fourfold in Hispanic Latino families of their child's genomic testing results. So I'll end it there and just mention our experience with BioMe has really encouraged our leadership within Mount Sinai to embrace genomic information and the future of bringing genomic information into routine clinical care. In 2022, we launched the Mount Sinai 1 million health discovery program, which aims to sequence the genomes of 1 million of our patients by 2028. And I will leave it there because I'm a little over time.
So we now move, thank you, Eimear, and we're fine with time, so no worries. Great pleasure to introduce the third speaker, for this session, which, as he knows, is the final talk of the final session of the final day of a wonderful, exciting conference. No pressure, for a talk entitled, What Do We Learn by Studying Biomarkers in Diverse Populations, from the National Cancer Institute of the NIH in the US, Dr. Arash Etemadi.
Good afternoon, everybody. Peter, you stole my line. I was going to say that I'm talking in the last talk of the last session of the last day of the conference. And look at the audience. I expected to be talking to an empty room, so I'm really glad. Thank you very much. So maybe a round of applause to yourselves for being here. Thank you very much. Okay. My talk is also special in that you won't hear the words genetic and genomic even once in my talk. Oh, I said it once, so twice. So my talk is, as Dr. Chambers was talking yesterday, as epidemiologists, we are also interested, although genetic diversity in genomics is of great interest, but at the end of the day, we are also interested in looking at exposures and how they relate to the disease. And probably less than about 30% of our diseases are determined, well, depending on how you define it, by genomic, but exposures are important. And this is the term I have just invented, precision exposure, so don't search for it. Trying to actually capture that exposure precisely and have an individualized exposure assessment in the population. So when you talk about air pollution, as opposed to talking about people living in central Singapore compared to southern Singapore and how that affects the risk of cardiovascular disease, you want to know about the individualized experience of all these people, what they go through, how much they are actually exposed to those carcinogens or whatever you're studying. So the challenges are, first of all, how do you quantify that individualized exposure? How do you capture that individual experience? And how do you combine the exposure from different sources that might have something in common, like a person who's exposed to air pollution at the same time they smoke, at the same time they use barbecued meat or something else. So how do you combine all these different things that are actually may share pathways, and how you make that mechanistic linkage between those exposures and the disease outcome or whatever you're studying in your community, in your population. So the way I see it, I see the biomarkers, like the panel I will talk about today, or the metabolomic panel of, for example, Nightingale we heard earlier today, as the way to translate these risk factors, these exposures, across different sources of exposure, across different diseases, and across different populations. And the term lingua franca probably summarizes the idea. As you know, this is the common language when people from the East were trading with people across on the Silk Road, or trying to have commerce with the Western populations. They try to come up with a common language, with a shared language, so that they can actually communicate. And in a way, I see biomarkers as that common language, that helps you translate exposure and risk across different populations and across different exposures. So I'm going to use esophageal cancer as an example to explain this. Esophageal cancer is not a very common cancer. But it's a cancer that has great geographic variation, and there are places where it is really high, places where it is not that, that much of a common cancer. And it's not very much explained by genetic factors. It's mainly an environmental disease. And we don't know really why this pattern exists. And also we know that there are different histological subtypes of esophageal cancer. Some of them are more common in the areas where it is a more common disease, whereas the adenocarcinoma is more common in the places where it's a less common disease. And I'm going to talk about 3 areas of the world where we have studied esophageal cancer. And the first one I'm going to start with is in the Middle East. So this is an area called Golestan. It is in the northeast of Iran. It's part of the so-called Asian esophageal cancer belt, which you see in gray in this map. And it's one of the highest risk areas of esophageal cancer in the world. And because of that, there was a collaboration formed between the National Cancer Institute, the IARC, and the Digestive Disease Research Institute of Tehran University to study the esophageal cancer in Iran, called the gastric and esophageal malignancies in north of Iran. They're nicely coming together as Gemini. It's a nice, acronym. And we had 2 studies, a case control and a cohort by chance. So the core of this study is this cohort study called the Golistan cohort study, recruited in 2004 and to 2008 in the city of Gombad and 300 villages around it. More than 50,000 people above the age of 40. It's mainly a rural area. At baseline, we collected lifestyle questionnaire, risk factors, blood, urine, hair, nail samples. We repeated some of those assessments in 20% of the population. And we have an active ongoing follow-up with very little loss to follow-up because it's relatively closed community. So we have over 20 years, we have only had 500 loss to follow-up. So there are 3 main types of tobacco in this study. 24% of men smoke cigarettes, as other parts of the world, this is the most common one, but it's mainly men who smoke cigarettes. Then there is NAS, which is a chewed tobacco. It's also common in parts of Central Asia, and about 7% of the population chew it. And then there is water pipe or hookah, which is about 1.2% of this population smoke it. So these are the main forms of tobacco in this population. There is also another exposure, which is interesting to see how they accumulate. About 17% reported using opium, and they use either raw opium or minimally processed opium called shira, and they mainly smoke it or take it orally. It's like, for 17%, it's become only about 40% are actually addicted, and the rest is kind of like a recreational form of use. So the biomarkers I'm going to talk about fall into 2 categories. Some of them are tobacco specific. The ones on the left are they're mainly nicotine metabolite or nicotine products. Nicotine itself or its metabolites, and then TSNA, or tobacco-specific nitrosamines. And the ones on the right are non-tobacco specific. They come from other sources, like PAHs, polycyclic aromatic hydrocarbons, like phenanthrene here as an example, or volatile organic compounds, or VOCs, like acrolein, benzene. These are the things that are used in chemical industry a lot. So cigarettes, tobacco, burning tobacco produces both groups. But things like air pollution, wildfire smoke, or even using charcoal in barbecuing produce the ones on the right, the non-tobacco specific type. And what really inspired us to study this more is when we were looking at the PAH DNA adducts. Okay, this is another reference to genetics, but it's really DNA adducts, not genetics. So when we were looking at the PAH DNA adduct levels in the non-smokers in Golistan, we saw that it's much higher than Dutch smokers, and even it's higher than Czech coke oven workers, which are really exposed to high levels of PAH because they are occupationally exposed. And this is something that you see in other places with high rates of esophageal cancer. So we went ahead and joined a collaboration with CDC. And they have developed this panel of exposure that they use in national studies across the US. The panel measures nicotine and other tobacco alkaloids, 7 biomarkers of PAH exposures, 20 biomarkers of VOCs, and 4 tobacco-specific nitrosamines. And the results showed, so the first set of results I'm showing just 2 of these PAH biomarkers. As you can expect, you can see that cigarette smokers, water pipe users have higher levels of these 2 PAH biomarkers, but NOS users don't have that high levels because they don't burn it. So because these are mainly products of combustion. But the interesting part is when you compare these to the NHANES, this is the US survey, and you can see that the levels of some of these PAHs in Golistan, even among non-tobacco users, is higher than tobacco smokers in the US. And that's very interesting observations to see where this comes from. As you have noticed, this graph is really poorly made. So for early career investigators, don't make your graphs like this. But the reason is that I'm hiding this part. The people who are using opium have even higher levels of these, much higher levels of these PAHs, and those who use opium and smoke cigarettes have even higher levels. So this is like how these two exposures actually have similar effects, have produced similar biomarkers, and when they are used together, the levels are even higher than that. The same is true for these 3 VOCs. Again, I'm showing 3 out of the 20 we measured. The acrolein is a respiratory and cardiovascular toxicant. Acrylamide is a carcinogen. Benzene is a carcinogen and also a cardiovascular and reproductive developmental toxicant. And benzene is probably the most important cause of leukemia in smokers. Again, you can see that cigarette smokers, water pipe users have high levels. Some of these levels are really comparable to the US levels, but for example, for something like benzene, you can see that while in the US the average level is really low, even among smokers, it's much higher in the Golestan population. Again, now you know the trick. I'm going to show the opium users. Now, among the opium users, the levels are much higher, and for some of these VOCs, like this one, acrylamide, it's by far higher than cigarette smokers, so it seems that a lot of this is coming from opium, while it is a less known, at that time it was a less known carcinogen. And we looked at how these replicate 5 years apart in the samples from the same individuals, and the correlations were really good, so making them very suitable as an exposure assessment in a disease study, which we did by looking at the nested study of esophageal and lung cancer among the participants of the cohort. And this is a very busy table. I don't want you to go into details, but we found 4 significant associations for 4 of the VOCs in non-tobacco users, in people who were getting these VOCs from environmental sources, mainly acrylonitrile, which is a group 2A, which was a group 2A carcinogen, probably carcinogenic according to IARC, but moved to group 2B exactly because of lack of this type of evidence, epidemiological studies with individualized measurements. Acrolein is a group 2A carcinogen. Propylene oxide is possibly carcinogenic, and 1,3-butadiene is a known carcinogen. And we saw associations with one of the pH biomarkers we measured, but it was not statistically significant. There is a lesson to learn here. We did a nested study matched on place of residence, and it turns out that the biggest driver of PAH exposure is where you live. So because they were matched, we couldn't see the difference between cases and controls. So let's move to South America, an area in southern Brazil called Rio Grande do Sul. And those of you who are familiar, you know that they are big mate drinkers. They love their mate, and they carry their gourds all day drinking mate. And it seems that mate could be another potential source of pH exposure. So we looked at people who were never mate drinkers and people who drank daily less than 500 milliliters, 500 to 1,500, and more than 1,500 milliliters, so 1.5 liters of mate a day. So that's a lot of mate. And here I'm showing the 4 groups of pH biomarkers according to how much mate they drink and whether they smoke cigarettes. So again, translating the 2 exposures and how they add up together. And it shows that both smoking and mate drinking contribute to the level of pH in this population and can be an important source of these potentially carcinogenic exposures in this population in southern Brazil. So another place, now moving on with the same set of biomarkers to East Africa, Kenya is another place where the rates of esophageal squamous cell carcinoma is really high. Bomet in West Kenya is one of those places where we have set a study. Here, there are high rates. Everybody knows that a lot of people come with esophageal cancer, but there is little cancer registry data and few formal epidemiological studies. It is very common in both men and women in Tenwick Hospital, where we did this study, and there are about 200 cases a year, and most of them are young. The point is that most of them come at very young age that you don't see in other parts of the world being common for esophageal cancer. Now, In this graph, I'm showing the levels of these 7 biomarkers for PAHs in the 3 populations we have talked about so far. And hence, the US population is in orange, it's the lowest level. Then we have match study in Brazil, which we know mainly Mate is responsible. Then we have Golistan, which is the one in gray, which has higher level for most of these PAHs, and it's probably because of indoor pollution and the type of food they're eating. And now this is in Africa. In East Africa, in Bomet, where we measured these biomarkers, the levels are through the roof. So the level of these metabolites are 2.4 to 28 times higher than any other population that we have measured. And this is the same lab, the same method, exactly the same standards of measurements. So everybody uses wood as a fuel in that area. That's probably the main source. And particularly when you look at what affects the level of these pHs in these populations, cooking indoors, being a female, so being more in the kitchen, exposed to wood, younger age and lower education are the determinants. So we tried to segregate and see what are the groups that are mainly exposed to these PAHs. The first one is those who cooked inside their main living area. So there was no kitchen. It's just the same place where they sit and they are together, they cook. Then the second one is a separate room in the house. The third one is separate room outside the house. And the last is when they cooked outside in the open, and those, mainly men do that. So that's why women are exposed to very high levels of pH, while men who mainly cook outside in the open are not exposed to that much pH. And this is what the kitchen looks like. So mainly, it's very poorly ventilated, a lot of soot on the wall, and the wood burning actually exposes them to very high levels of pH. So we also endoscope these people. Those of you who have undergone or done endoscopy know that it's really difficult to convince, ordinary people in a study to come and being endoscoped. But we endoscoped them and looked at the early precursors for esophageal cancer, which is esophageal dysplasia, and then looked at the pH levels as a risk factor for this dysplasia. And although all of these pH biomarkers were to some extent associated with the risk, one of them, which is 2-NAP, this is the same one that was associated with the risk in Golistan, was associated with the risk of esophageal squamous dysplasia in Kenya. Warning, this is a small sample size, so that's why our power was not enough to see many of these, but we are following up on the study with larger sample sizes. So, biomarkers, in the words of Sergio Leone, the good, the bad, and the ugly. So the good. They allow you to quantify and validate your exposure. They let you actually go from talking in general about air pollution, smoking, 20 cigarettes a day, to something that you can measure, you can pinpoint, you can compare, you can add the exposure coming from opium to air pollution to barbecuing meat into one single thing. You can compare across populations. You can compare the level of the pH biomarker in the US with Golistan, very different worlds. And then you can you can combine them to look at direct mechanistic evidence. So this opium, which is a known carcinogen, produces PAHs. That could be the link between using this exposure and the outcome. The bad. It's usually mainly reflective of recent exposure. Although we showed in repeated samples that people who keep smoking, they don't change their behavior. There's very good correlation between samples taken 5 years apart, but still, it has a limited half-life. You have to find a biomarker that really reflects longer-term exposures, et cetera. You have to have suitable biospecimen. So the ones that I showed you, I forgot to say, they're urinary biomarkers. And many cohort studies do not collect urine because it's messy, it takes large volumes, et cetera. And then you have to have a reliable lab. We were lucky to have the CDC lab do this for us, but sometimes you do not find that lab that can do this for you. And the ugly, the price. Well, as many other things that you do, usually the biomarkers with this sensitivity are pricey, and it's not feasible to do it at many cohorts, particularly from LMIC, so those are the challenges. And with that, I would like to thank my collaborators. It was a great teamwork. And again, thank you very much for listening on this last session of the last day of this wonderful conference. Thank you.
Thank you, Arash. And we'll ask the other panelists to come up, take their position in order. And I would remind everybody for one last time, pigeonhole, pigeonhole, pigeonhole. Right now we only have one question. It's a good one, but we only have one. So please go to the pigeonhole, give them some really challenging questions for this final Q&A session. So I'm going to activate this question.
Sounds like yours.
Maybe I'm not. First of all, I'm going to put on my glasses so I can see how to activate the question. But I can read it out. I understand a question. The question is a bit out of the modern genome data, but has anyone looked at the ancient genome and the relatedness to what we're seeing in modern populations? I think there were some hints of it through the meeting, but Eimear, do you want to take that one first?
Yeah. So the quick answer is yes. We know that even though most of the archaic human species are extinct today, for a large part of our human history, we coexisted often in the same place as many other species, and we have evidence from DNA that we introgressed or mated with at least two species, Neanderthal and Denisovan, probably more. There's evidence, for example, in African populations that there's probably a archaic species integration there too. And we know that some of the genes we inherited in those integration events impact health outcomes today. So immune function certainly would be one of them. There's an HLA, I think it's HLA-B star 73, that we think is Denisovan in origin, I think. There's also toll-like receptors that we think are Neanderthal in origin. It could be the other way around. And other traits, skin and hair for sure, neuropsychiatric disorders actually as well, in addition to cardiometabolic disorders. And some of these are through signatures of adaptation, we think. So for example, our high altitude adaptation maybe also thanks to some integration from Denisovan. Some of them, like many variants that arose through adaptation processes, can also have knock-on deleterious effects later in life. I hope that answers your question.
Anything from either of the other two panelists? No? Okay. So I think we'll move to, I've got one here that we'll address right at the very end. Let's activate this one. And it's for you, Arash, I'm guessing.
That is a great question, and thank you very much for asking it, because otherwise I would have felt really bad that nobody asked me any questions. So actually, it seems that for mate, it's the process that is responsible for pH. I mentioned it is the pHs are produced as a result of combustion of organic matter. And pH leaves are usually smoked through the process. They believe that it gives them a better taste or it's more refreshing or whatever. So that smoking process seems to be the case. Actually, we did a study. We did several studies on that. We went ahead and tried to we got batches of mate from different producers. And the ones who said that they smoked their leaves, some of them that said they don't smoke their leaves, etc. And then this was a fascinating study because we were making mates and then sending them to the lab all the time. So we actually did it with NIST, another institute which does standardization, etc. So, and they measured them and they showed that the pH leaves that didn't touch smoke had better, lower levels of pHs. And then one of the producers contacted us. They read scientific journals in Rio Grande do Sul. That's good. So they came to us and said, look, we're optimizing our processes, we believe that we can produce the good tasting mate without smoking them. Can you test these for us? And then give us, not a certificate, but publish the results and show that these are healthier forms of mate. So they sent us a lot of that. We didn't use any, we just sent them to the lab. And then the result was actually showed that these were really healthy, lower pH content in those mates, and we published that as well in the journal. So it's probably the process, the smoking process, that produces the pH in the mate.
So Arash, I'm going to stay with you since you were happy to get a question. Here's another one.
Okay, what is the requirement to replicate to the best level any biomarker discovery study at all settings? That is a very good question. I would say that the most important one is the lab. God knows how many different labs we went to measure these pH biomarkers. And they came up with really, they were very reputable labs. They were very good. But then we looked at the CVs of the assays we sent, how we sent pooled QC samples, and the results were terrible. So we saw that there was one study that actually we did the pH DNA adducts. Again, I'm not saying where, but it was a very good research organization in Europe. And the results were so much all over the place. They repeated the same sample 3 times. And those 3 times, you could not even average them because some of them were, very low. Some of the results from the same sample were so high. So I would say that finding a good lab, a reliable lab, which has great quality standards and, having great collaboration with them. And we're lucky, really. The CDC lab we were working with, they were top-notch in what they do. So I would say that for replication, a good laboratory collaboration is the key.
Thank you. And we're going to go now to Dr. Tai. And a question about how to precise determine which conditions to prioritize for the pilots.
We chose conditions that, first of all, somebody wanted to do something about. We felt very strongly that we were not going to be able to. I don't know whether you've worked with doctors before, but doctors don't listen to anything. And I'm the only person who's allowed to say that. We don't listen to anybody. And then I think we chose them based on actionability, but we also chose them based on their ability to define what the current care pathway was. And actually, a lot of things fall away at this stage. A lot of people come to us and say, well, we want to do this thing differently. And then you ask them, how do you do it now? And a lot of them can't tell you. So I think it was really about getting groups of individuals together who are not only prepared to work with each other and share resources, but also to take on these ideas about how we should be thinking about these problems. It's really about sort of shared values and building communities that trust each other.
Thank you. Eimear, back to you. Could you elaborate more on the services of Genomic Health Clinic at Mount Sinai?
Yeah, sure. Actually, it sort of piggybacks a little bit from E Shyong's answer, because we also, in our health system, the very first thing we had to do was build a coalition of the willing, and those physicians who were willing to be early adopters of this information. And we did not proceed with things where we could not find those physicians, even if the health management evidence or the genetic evidence was there. But if we couldn't assure appropriate health management by physicians in our health system, we could not continue. Yeah, I'm happy to talk about the Genomic Health Clinic. We were pretty excited about this clinic. It doesn't sit in executive health, where a lot of clinics like this may sit in other health systems. Anybody from our health system can, by themselves, just get an appointment with the clinic. They can also be referred. We get a lot of referrals, maybe most from primary care, some from psychiatry, for other reasons. People come to the clinic for lots of different reasons. Some because they worry about a family history of risk for a certain disease. So we get a lot, for example, who may come in with worries about Alzheimer's in their family or heart disease in their family. Some because they were adopted and they want to know, they want to fill in the picture about their own genetic risk in their own health. And others because they had a family member who tested positive for pathogenic variant for disease and they didn't have access, so they come in through the clinic for access. In addition to that, we see the participants who come through the BioMe program, which is different because that's research sequencing that we then need to clinically confirm in order to return the results. We only return results that are clinically confirmed independently. And now we're moving to the Mount Sinai million, where we're scaling up from 70,000 soon to be 1 million. In addition, today we're returning results for 1 in 35. We've got pilot programs to extend that gene list, also to bring in polygenic risk information into clinical care as well, where the evidence is really mounting, where that will be useful in our health system. So we expect to see some of those patients too. The Genomic Health Clinic, I guess the last thing I'll say is, we see it as a triage clinic. Sometimes we're triaging back to medical genetics if a case is complicated, or to cancer counseling when that's appropriate. Sometimes we're triaging to multidisciplinary specialty setting that treat people at high risk. That's often what that clinic is doing. But a lot of what we do as well is education into other practices to empower physicians in those practices to be able to increasingly become familiar with genomic information.
Okay. Okay, they're all up there. The one that's coming up top has also got another question that's very similar to it. So I think we got a question for all of you, and probably 5 votes if we put those two together. Thank you for the interesting talks. Do you expect the emergence of population health data to cause discrimination for certain groups? If yes, how can that be resolved? Start at the far end with you, Arash, and come this way.
Yeah, that's a really great question, and I understand this is a challenge for when you're talking about these groups, etc., ancestries. It might imply that certain groups are discriminated because of this, their predisposition or the genetic background, etc. I think the key lies in education and trying to, instead of labeling different groups with certain disease patterns, etc., try to show that this is not something that is attached to a certain ancestry, or is not something that is really can be discriminated. So I think training, education, and making the public understand what really these data mean is the key. That's my 2 cents.
Eimear?
Yeah, I agree. It's a great question. I think some of the ways that we've really tried to think about this at Mount Sinai is through forms of community engagement. And when I say that very gently, because what we do doesn't look like most people would think of as community engagement, because sometimes it's hard to find communities in New York. It's a big, very multi-ethnic city, and where do you go to find a community? For example, we found a pathogenic variant underlining moderate to severe forms of hypertrophic cardiomyopathy at 2% in Garifuna community. It took us about 6 months to try and find out where Garifuna communities are in New York City and how we could start to interact with them. So it doesn't look quite like that. What we tend to do is we have a genomic stakeholder board of community members who give us advice on a continuous basis about information. And we also help communities themselves who may have varying levels of trust of even the health system, be able to empower themselves, sometimes even to set up their own genetic screening programs outside the health system. So there's some of the ways that we do that, but I think it's important to be constantly thoughtful about the ways in which this information can have inadvertent bad effects for communities and individuals.
Thank you. Professor Tai.
Gosh. I'm not sure that population health data is what causes discrimination. I think it's the way human beings use it that results in discrimination. You know, in as much as we've talked about sort of biology and that human beings are human beings are human beings, at the ethics session on day one, we heard that ethics and values, it's about the people, the people, the people. I think the conversations are important. I think the ongoing conversations and the systems and the structures that allow conflict resolution to occur without polarization. I have no idea how to do any of that in today's society. But I mean, we see this sort of extreme polarization across all societies as we move forward. And my guess is that the solutions are going to lie it's going to be the same as we bring people together in communities. And in some instances, we will need legislation for protection. And it will very much depend on what's happening in that particular community.
Can I add a point, Peter? So there's a book called The Biases That Divide Us. I suggest that you read it. The central idea is that it's not the information that usually causes this kind of, you know, the divisions. It is the inherent bias that abuses whatever information it's fed to you know, deepen those divides, those discriminations. So no matter how much, sometimes no matter how much correct information you give, those biases are still there to segregate people. So again, in line with what I was saying, probably addressing those biases, going back to the roots, and then understanding that they exist. Even if you try your best, they still exist. Those biases exist, and trying to challenge them or face them and try to, you know, see how you can deal with those biases might be the key. Giving information is not, these health information is not necessarily what causes those divides. It's those inherent biases. Sorry.
Thank you. And I mean, it feels like a recurring theme through the whole conference, this issue of the power of the data, but also what we bring to it as humans and the biases we take into it. I'm going to go, there's two for Professor Tai. They seem to add to each other. One's about where do you go with clinical pilots next, and the other is more specific on diabetes and adiposity. So, over to you.
I'll answer this one first because I don't know the answer to the other one. Although truthfully, I think you've caught us in Singapore, at least you've caught us at a point where we're exactly asking that question. I don't know what the right approach is. I think we're going to take the same kind of approach that we took towards the pilots. We're going to bring these stakeholders together around the table, try and figure out amongst ourselves. It will be an act of will, right, that makes us try to resolve differences and build something for the entire population and make sure that we sort of do have a consistent sort of vision. Diabetes and adiposity is a tricky one. You know, and I think that it sits in that space where you get to ask the question: if there is an intervention, why not just do it for the whole population? And I suspect that the answer is probably going to be some combination. And in fact, in some of the talks today, we've seen that societal level and population level interventions that shift the entire distribution of risk to the left or to one side can and should be emphasized, and particularly if they're going to be good for everybody. But there will always be some people who are left behind and remain in the tail of that high-risk group anyway. And I think our views on equity should also be that if they're left behind, then we should try and bring them in too. And I think that's where a slightly more precise approach may come. Now, is that going to be a genetically driven solution? I don't know. The genetics may be informative to some extent, but I think we need to think very hard about how it informs a specific intervention, or whether there are interventions that can be that are just behavioral and address the other parts. The other speakers talked about the other parts of the determinants of health other than the genetics and genomics.
So, clock says we have 1 minute and 24, 3, 2, 1 seconds left. Just to each of you in turn, thinking about the whole 3 days, about the last session, about your perspective, can you just give us a 30 seconds? What's the one thing you want the audience to know? Arash.
That is, I hadn't thought about this. I should have, because we always ask this from everybody. So I would say that the biggest, I mean, if I want to summarize what I learned and what I learned from all these meetings and all these gatherings that we have, is the value of collaboration, how we can come together with different disciplines, with different ways of thinking about problems and getting out of our narrow vision about what we do and the narrow environment we are working, and trying to establish networks and bridging to other people. And I think this was a great setting to actually foster that kind of collaboration and capacity building.
Eimear.
Well, I think we've heard this a lot through this meeting, that genomics is not the biggest slice of the pie. I'd like to modify that a bit. Sometimes genomics is a big part of the pie. Maybe it's the whole pie for some people in some parts of their lives. For most of us, for most of our life, it's going to be a small part of the pie. And I think we have to remember that this acceleration of our ability to generate and build evidence around genomic information goes hand in hand with all sorts of other data-driven ways we're bringing data into making decisions, whether it's in healthcare, public health, or other sectors. And the way that we think about genomic data we can learn a lot from other fields like machine learning and the ways in which we de-bias how we use information. The nice thing about genomic information is, in theory, it should be pretty agnostic, particularly if you have genomes first, that you should be able to measure variance. So we know, of course, in practice, the evidence isn't even across different humans on the planet, but we're making strides to get there. So I would say, I hope for us as a community, if we're coming back in 10 years' time for, the IHCC, that we should be hoping and pushing that the work that we do and how we impact, how we use genomic information, should not promulgate health disparities from where we are today. We may not make the world better, we hope to, but we shouldn't make it worse. So we need to look out for those areas where we could possibly do that.
Finally, for our local speaker.
I think what you want to do is to look around the room and realize how diverse this group is, and the fact that they stayed around right to the end, I think, tells you how passionate they are. One of the things, it really doesn't matter where your entry point is. I think it's important that we just start to do something. And the nice thing about this community, and this is my first time at the IHCC, but the nice thing about this community is, if you ask people what they did before and what went wrong, they will tell you. And I think I think that there's so much that we can learn from each other, and I look forward to the next time we get together again.
Thank you. They've also done a great job of stealing some of my closing remarks, so thank you. You got your own back, Arash. I would like to close this session, and I'd like you all to thank the panelists for their contributions.
Are you going to answer that question, the first one? The first question.
I'm going to answer it. Well, I'm not, but I'm going to talk about it. The question that I've been ignoring all this time is, where is the next IHCC? And we don't have a location. But we have I think we have some really strong principles coming out of this meeting of the right way to do it. And I think we'll be looking to find a new partner who will work with us in the way that Precise has worked with us. So that's my holding answer for now. So thank you.